The endowment was established in memory of Sudha so that the Division of Physical Therapy at Ohio University may pursue innovation and excellence in PT, education, and practice. As part of the endowment's mission, we have invited Dr. Gail Jensen for a 2-day series of presentations and workshops centered around the topic of clinical reasoning. Dr. Jensen said I don't need to read all of this, but she has quite a few accolades, so I would like to make sure I hit them all. Dr. Jensen is the Vice Provost for Learning and Assessment, Dean Emerita, and Professor of Physical Therapy at Creighton University. She is known nationally and internationally for scholarly contributions in expert practice, clinical reasoning, professional ethics, and interprofessional education. Dr. Jensen is author or co-author of more than 90 publications in peer-reviewed journals and has co-authored 13 books, including the 4th edition of Clinical Reasoning in the Health Professions, and in 2020, Clinical Reasoning and Decision-Making in Physical Therapy. She led the research team that completed a national study of excellence and innovation in PT education, funded by the American Physical Therapy Association and several APTA components. She serves on a number of editorial boards and most recently became an editor for The Clinical Teacher. Dr. Jensen received her PhD in educational evaluation with a minor in sociology from Stanford University. She holds a master's degree in physical therapy from Stanford University and a bachelor's degree in education from the University of Minnesota. Please join me in welcoming Dr. Gail Jensen.
Thank you. Let me start by saying what you really need to know about me is I'm a physical therapist. And you're all colleagues, are going to be colleagues here in this room, so that's kind of the level that we're all at. And I've just had a great session with the DPT 1s and 2s, very impressed with the engagement and spent time with the faculty already. And I'd like to say what an honor and privilege it is to come to your institution and your program and to see the generosity of the Agrawal family. That is really terrific, and what an exemplar for our profession. We're still rather young as a profession, and to see how we develop the ability to raise scholarship funds and funds that really help with development. I'm at the age where I think about that too, and I can tell you I have a scholarship fund at Creighton University, so it's really, really important work, and it leads to your education and what you will do in the field, and you will do good things. Okay, I'm going to go rather quickly. I've got a number of slides. I don't want you to go to sleep. That's why they brought the house lights up just a little bit, which is good. Okay, these are the objectives. You all know about objectives, and I'll show you the simplified version, which will be easier to understand. And we're going to start at the bottom. We're going to build a foundation about what is clinical reasoning. Then we're going to make some connections, some theory and concept connections. So it won't be too painful, but it's important. And then we're going to end with some practical strategies about teaching, learning, and assessment. So let's build a foundation. Let's start with definitions. Well, here's the deal with clinical reasoning. It's complicated, and everybody thinks it's a different part of the elephant, right? What is it? Is it thinking? Is it knowledge development? Is it context? Just what is it? So there is a lot of ongoing dialogue about defining clinical reasoning. You're going to see the complexity here. So I've highlighted things that are important to point out. So clinical reasoning is both about cognitive and non-cognitive process. Cognition, knowledge, thinking. But you've got to interact with your patient, and you've got to understand the patient preferences, and that is really important in the health professions like PT, OT, those of us that spend time with patients. And that definition is from a book by Trowbridge, Renzik, and Steve Durning on teaching clinical reasoning, a great book. Here's another one from Joy Higgs and colleagues. I've been part of that book on clinical reasoning in the health professions. What I like about this definition, context-dependent way of thinking and decision-making in professional practice, construction of narratives. And we're going to say more about that. And here's another definition coming from Pat Benner's work. Patricia Benner, well known for her work in nursing on novice development. The ability to reason about a clinical situation as it unfolds. Patient, family, concerns, and context. Good nursing judgment never ignores the concerns or life world or lived experience, which is on your PT, it's on your wall in your department. It says lived experience. And judgment is shaped by the context of the situation. So you can see how the complexity of clinical reasoning. And here's one more. And this is from a paper that came out in 2006, I believe. It was redone. They did an update of it recently. And they've revised the definition, which is important. Contextually situated and socially mediated activity. So what you're seeing going on in medical education in clinical reasoning is attention to the social context of what we do in practice. Really important. And which is why it's not easy. And here's one more. This is the last one. Diagnosis is co-created with the patient. The diagnostic team includes a broad array of health professions. And I was talking with faculty this morning. There's a lot of talk about management reasoning in the interprofessional team. It's not just the diagnosis, as you know, particularly for those of us that have to manage patients. The diagnosis is one piece, but not the only piece. So that continuous thing of your ability to think analytically, cognitively, but also with some non-cognitive things. Okay, so we already talked about this with the students. What may be unique about clinical reasoning in the health professions? So let me ask you a question. So do we have other health professions here? If you're from is this the dean? Yes. Oh, okay, I can call on the dean, all right. I already heard you're from speech and language. So what's different about clinical reasoning in speech and language, SLP, from PT or from others? Well, what's unique about your clinical reasoning process?
So I think because communication usually involves another person, so we have to think a lot about who's that audience or who's the person you're talking to. So there's a lot of contextual kinds of considerations in clinical reasoning.
Yeah. So the context is important, but we all have kind of a signature pedagogy we call a unique piece. So, and I'll talk a little bit about movement in the role of PT. And just to appreciate, that's the snow in our backyard before about a week ago in Omaha, Nebraska. I thought you'd appreciate that. We had a lot of snow. And clinical reasoning has been, there's a lot of focus on it across the health professions. These are various books from places from speech and language to nursing to PT to health professions. And that book, Teaching Clinical Reasoning, it's a great book, and it covers a very basic. All right, so what's an example from PT? There's too much text here, but to point out the role of movement and how movement is part of the clinical reasoning in physical therapy is central, I think, to our profession. And a recent paper by Nicole Christensen and colleagues that came out in December in our PTJ is a very good one. And it's built on some of this work, which you can see it pulls in the collaboration with the patient and how we understand the movement problems, issues with patients. Okay, so why is this so complicated? Well, you heard, it's complex, it's context, we have changing conceptions. Challenges to novices. Here's your challenge, students, whether you like it or not. Students, you like certainty and you like to know, you like to be what we call rule governed. Now we heard from students today, you discussed very much about you like the uncertain, you realize how important the uncertainty is. But generally you want to know, you want to know what to do. You want to know the answer. So we've got to help you progress so that you can navigate a little bit of that uncertainty. Because that'll help you handle the context. And this all relates to how we talk about adaptive expertise or adaptive learners, and I'll say more about that. In clinical reasoning, as you see, it's the elephant. There's confusion over what it is. We need to connect it with learning, and we'll make those connections. It's often more implicit than explicit. Your faculty here are very focused on making it more explicit. They're doing a good job already, but they want to make it more explicit. And we need a roadmap. So we need to think about how are you progressing as a learner across the continuum and into practice? And is it everywhere and nowhere? That's kind of the curricular issue. Do you have a course in clinical reasoning? Or do you integrate it in a way that learners have a sense of what that is? Not just critical thinking, but clinical reasoning. Okay, so you ready for theory? Yeah? You've had your lunch? Right, okay. All right, okay. All right, so I'm going to say a bit about learning here. I'm going to start with clinical reasoning is not a skill. And those that write deeply about this, it's not a general skill because you've got to connect knowledge and thinking together with the context. And it takes practice. It takes deliberate practice. So we can't just think of it, oh, it's a skill. You've got it, check. No. You've got to organize your knowledge. And this is where we need to do more work in the profession. How do we help you organize your knowledge? You've got to build your own knowledge base. And then the situation keeps changing, that context, and how do you have the ability to navigate that uncertainty, to stay with the kind of, as you're trying to figure it out, and engage in different types of reasoning, and we'll talk more about that. These are the three things that are common to all of us in the health professions. Habits of head, mind, hand, and heart. Hand also including, clinical reasoning goes across all three of these. It's not just in one of these dimensions. And the study of the professions that was done by the Carnegie Foundation of Nursing and Medicine, we did one of PT, there's evidence to say we need to pay more attention to professional formation, your habits of heart, your ability to navigate, to be resilient, to have grit, and so that you don't become burned out, and so that you can stand firm in what you do with your patients. And how many multiple choice tests have you? How many think you've taken more than 50 multiple choice tests in your life? Yes. So they're good, they're great, particularly when you have a large class. How are you going to do a knowledge assessment? Yes, multiple choice tests are helpful. They're often high stakes exams, but the right answer is not always what happens in practice. It's the uncertainty. And how do we help you balance that? And how do we help you with your own progression? That's our challenge on the education side. This is one of my favorite slides. We spend far too much time in the university and in our programs on this side. We pour it in, declarative knowledge. You must feel like you're drinking from a fire hydrant sometimes. But then you get into practice where things really happen, very exciting, right? You've got that knowledge, declarative knowledge, procedural knowledge, how do you do things? So you got to put that together. But you've got this reflective component, which is really important as you're thinking in practice, while you're practicing, not just back on practice. That's your reasoning. We call it practical reasoning. And that helps you manage this uncertainty. So how do we get you to develop, I'll talk more about your metacognitive thinking. And this situated learning that occurs in the community of practice is the most powerful learning. And we talked about that this morning. You made some good examples and comments. Okay, now, as learners, guess what? We're poor judges of our learning. Learning that is deeper takes more effort. We're not good about when we're learning well. Learning that's easy to do is usually gone tomorrow. As you know, memorization, you're going to hit the wall. If your only strategy is memorization, you will not be successful. And how many of you know, reading and rereading texts and using your yellow highlighter, it's a strategy, but it can't be the only one. It really is least productive in what we know about learning. So this is a recent book, an update of the well-known book by Ambrose. And these are 8 research-based evidence on what we know about learning. So we know that learners differ from each other, and we've got multiple dimensions that we've got to navigate. But learners' prior knowledge can help or hinder. So how you build your knowledge and how we connect with what you know or don't know, that's in our world as faculty members. And then we have to help you provide scaffolds or strategies for you to organize your knowledge. And your motivation is really important. You had great motivation this morning. I'm sure you show that every day of the week, right? Right? Yeah, I see it. Come on. I want to hear a little response. Okay, so to develop mastery, you've got to practice. And a lot of the work that's going on in competency-based education is really the nugget, one of the nuggets is this mastery learning. I'm fond of saying, okay, if you're going to be a mastery learner, it's not just are you 80% competent, because which 20% do we not want you to be competent in? We want 100% competency. And that's going to take practice. Feedback is really important. And so faculty have to give feedback, targeted feedback, timely feedback. The learning environment, the clinical learning environment, really powerful. Early clinical experiences, very important. They help you see that context as you continue. And then most important here is this self-directed learning. How we teach you, how we facilitate your ability to become an expert learner. That is the absolute, I think it's the holy grail of how you can evaluate your own knowledge and skill. You plan, you monitor, you have that self-monitoring ability, and this is all wrapped up in the model called the Master Adaptive Learner, which we'll get to in a few slides here. So you've got to learn how to learn. Most important here, learning is a process and not a product. And it changes over time, so you're going to continue to learn throughout your career, we hope. And it's something you have to do to yourself. It's not something we do to you. You do it. And there were really great comments this morning about that. So you got to think more explicitly about what that is. Okay, a little bit about theory. I've taught for a long time. I taught a graduate nursing course when I was in California at Samuel Merritt. And I was fond of saying this, so when I was leaving Samuel Merritt to go to Creighton, they gave me a T-shirt that says this, "Theory's your friend." I still have it. I like it. I think it's nice. Okay. All right. So these are learning theories. Here's the deal. If we just focus on cognition, information processing, very deductive kinds of thinking, which is important, and behavior, okay, those are the procedural knowledge, skills, right? And don't consider the culture, the social, cultural interactions, and the context, what's happening in that community of practice, what happens. All four of these learning theories apply to clinical reasoning. For far too long, we've been very focused. The early work in clinical reasoning was all about deductive information processing. And it has changed quite a bit. And it has changed mainly from the work that was done in health professions like nursing and PT and OT, really pushing hard on the patient context and how important that is to the work that we do. All right, so why science? The science is important. Somehow when we put science to another term, everybody thinks it's great, right? It's learning science, right? Science has a lot of cachet, but it's important in that there is this deep conceptual understanding that's important. And I'll point that out in another slide. We've got to build on your prior knowledge, but in order for you to do that, you have got to reflect. You've got to develop your metacognitive skills, and that's not just reflecting back on the action, that's your ability to reflect in action, to develop some conceptual kind of understanding and reasoning, which is deeper than where we tend to focus, which is on facts, declarative knowledge, how to do things, procedure. So we want to prepare an adaptive learner. That should be our ultimate outcome. And this work that's been going on is based on work out of the National Academies of Practice. It's been great to see the movement in health professions in this way. So this is a visual. We've got to get you to do all three of these. We tend, again, to spend too much time on the top. That's more surface learning, but the conceptual knowledge, the understanding, really makes learning stick, and that's how you create your knowledge structure. If you just memorize manual muscle testing stuff, right, doesn't stick with you. But if you understand the basic concepts, those threshold concepts, right, then you don't have to memorize all that stuff, right? So that's a deeper understanding. What are our challenges? It's difficult. It doesn't replace content. You still need content. We need to help you become fluid. So we need to find teaching strategies to get you to be curious, to think about complex problems, to think about not just what's the right answer, but what don't you understand? Where is the struggle? And then you have to practice. Cases are great places to practice. Clinical cases bring that clinical reality, very important, but we've got to help make those connections. And compare and contrast. Here's a case. Somebody has osteoarthritis. What would this case look like if the patient presented with rheumatoid arthritis? How would that change that? So that's up to us to challenge and facilitate your abilities. And again, these last two are really, really important. Okay, deep learning, how you do that, you've got to connect new ideas and concepts, integrate knowledge with conceptual systems. Some of that is theory. We'll talk more about clinical reasoning and how you develop more pattern recognition in your reasoning. Understand knowledge is created, particularly in the clinic. As you listen to the patient, as you develop your clinical knowledge, your pattern recognition, you begin to form these kind of understandings of, I've seen this before, sometimes called the illness script. I've seen these presentations, and that's why experienced clinicians can take shortcuts. And then reflect on your own process of learning. I mean, how often do you think about this? I asked you that question this morning, how do you learn? Right. So we learn in different ways. I can tell you that what we're doing right now, lecture, this is a bad way of learning. The retention is not very good for a lecture. We've got to get you engaged. So I apologize for that. But your faculty are going to take this. You're all in a good place here. All right. Okay, so knowledge is more than facts, so there's a little bit of theory here. We stand facts, procedure, all right? But these two dimensions, the metacognitive knowledge, how to know when to use that knowledge. Is this the time? This I have to bring forward. This I have to find out. And that the conceptual knowledge, and I'll show you, this is where models are helpful. So this is where we need to do more work. And here's the other thing that we know about clinical reasoning right now, is that it is this adaptive solution. It is the context. And some people would argue, authors, that context is clinical reasoning. I mean, think about that. I think it is in a lot of our work. All right, this is one of my favorite slides. It comes out of a well-known paper in academic medicine by Daniel Schumacher and Bob Englander and Carol Carrascio. So what's the most important thing in this figure? Students. Somebody say it. What's the most important thing in this figure? What's the most important thing? Learning, yes. And it's your learning, right? So how you go from novice to developing more mastery or expertise. Also, what's central in this figure? Self-directed learning. Your ability to become an expert learner. Your ability to self-assess. Now, we know that theories help us, both cognitive, knowledge, and non-cognitive. Those are important. And you have to develop reflection, self-monitoring. These are kind of calibration abilities you have to have, as well as your self-confidence. Now, I worry about learners that sometimes are overconfident. I do a standardized patient experience in teaching ethics, and I can tell you the learners I'm concerned about when they do their reflection questions are the learners that go in and they write the reflection. They say, I nailed that case. I told that older adult if she didn't do these exercises, she was going to the nursing home. It was perfect. Now, that's a problem, and they thought they were great communicators, versus the learners that I was really confused, and here's where I struggled. I'm really interested in, and I asked them a specific question about struggle because I want to see what they're thinking. The other thing about clinical reasoning that is difficult is we have to get the inside out. We have to be able for you all to show the math. We can't it's not right answer. We've got to say, what are you thinking and how did you get there? That is really important for us and for you. So it's not about right answers, and it's about this, how you can struggle and manage the uncertainty. Okay, once again, the cognitive theories are dual processing. We'll talk more about, has to do with slow and fast thinking. They're different terms. I have another slide that points that out. Cognitive load. The human brain can hold on to about 5 things. Steve Durning is fond of saying, if you get over 5, if you get to 7, it's not going to stick. So that if we overload you and you drink out of the fire hydrant, this is not going to be good, and that's our fault. And then how we help you build your knowledge structure. Knowledge has to be organized in some way. It's not just, spit it back. You've got to figure out how you're organizing. This is where concept maps, and we'll talk about some specific tools. But these non-cognitive things, how situation aware are you? Do you see things in the clinic? Or are you just zeroed in on your examination and evaluation and all the questions you need to ask? Or all the screening processes? And it's hard. It's hard for novices to move along, but you want to be situation aware, you want to be engaged, and you want to see what's going on in that social cultural environment. And so clinical reasoning is fast and slow thinking. Fast thinking is what experts do. They take shortcuts, that kind of pattern recognition, but slow thinking is more how we teach you, that kind of deductive process. And it takes your ability to self-monitor that process. But we need to teach you both. You need both. And you'll see your clinical instructors often take shortcuts, and you go, how'd they get there? Well, you ask questions, which is helpful, because your questions help them think aloud, which is another really important strategy for everybody in the learning environment. When an expert thinks aloud, well, I asked this question because I heard this or I was thinking that. It's getting the inside out. Very, very important concept. Okay, so here is what can we do? Dual processing theory has to do with that cognitive ability of pattern recognition is the fast thinking, taking shortcuts. Master clinicians do that. Slow deductive type 2 thinking, more analytical. And what happens, what experts do, they use both. So when they're stuck, they'll engage in more deductive thinking to help figure it out. Cognitive load, this is our working memory. 7 pieces, 5 plus or minus 2. I think we're in error here. How many faculty think we do too much cognitive load? Do you see that? They all agree. Even your dean agrees, right? We're guilty of that, and it's finding a way to calibrate what you need to know and what's nice to know, because building that foundation of your knowledge structure is really important. And then deliberate practice. I've always been, I said to the faculty early this morning, I've been involved with a clinical residency program at Kaiser Hayward for 30 years, and I always was fascinated with, you'd see residents, therapists come and seek a residency program because they were interested in their clinical reasoning, and they would be so focused on practice and practice and practice. And then I'd say to the students, DPT, the entry-level students, it's like, they do it once or twice and they're done. It's like, you never do that, right? In the lab, do you keep practicing? So there is, how do we find the way to engage you in the practicing? But I don't think we spend enough time on deliberate practice of clinical reasoning. I think we spend time on deliberate practice of clinical skills, but not necessarily of the clinical reason. I think the profession could do a better job of that. And you can see we're more on the right side than the left side. Oh, and you get this, the communities of practice, again, what happens in the clinic, and the earlier we can integrate that kind of stuff, the better. Okay, what we know about, here's what we know about clinical reasoning from some of the research that's been done in PT. We know that clinical reasoning in PT is actually quite collaborative. That was one of our findings of an expert study, practice study we did years ago. It goes beyond the diagnosis. We're challenged, I said this morning, we're challenged by the human improvement. We don't have control over human beings. We don't have control over learners. You have to do something to improve, and that's complicated. It means we just can't fix it. Good manners, and we also talked about this morning, about burnout and moral distress and moral agency. Ethical reasoning is, my opinion, a very important piece of your clinical reasoning. And then your metacognitive process is key. Okay, what about reasoning models? I love this. Bob Englander, Dr. Englander gave a keynote at our education meeting in Philadelphia in October, and he had this slide. I looked at George Box, evidently a statistician, was saying, well, all models are wrong, but some are useful. And I think it's a good saying. There are all sorts of models, but I think models are helpful. They can be useful. Are they the right way? Not necessarily. All right, so here's a visual of slow and fast thinking. And I've used this for years. But here's the patient, and if you're doing backward reasoning or slow thinking or system 2, whatever you want to call it, you're doing more deductive, analytical thinking, weighing the evidence. If you're doing more pattern recognition, forward reasoning, pattern recognition, fast system 1 thinking, you already know, you have some clinical knowledge, and so you've heard the pattern, and you're matching that with what you know, and you can take some shortcuts. You're more intuitive. Now, the good news is we like to have levels of learners in the practice area, because novices, when you're with your CIs, when you're in the clinic, you're going to ask questions if they're taking shortcuts, and those are really important questions, because they may be intuitive. It's tacit. They're not even thinking, but they hear your question and they go, oh, yeah, I'll do a think aloud. Here's why I did this. So your questions are really, there's never a dumb question for a student, right? Never a dumb question. All right. So here's a model, ICF. You're familiar with the ICF. It's helpful. It helps us see a little bit of the context. So it's one model, and I think it's been used a lot in the neuro area and where we're dealing with complexity and disease. Is it the only model? Absolutely not. But it helps you see where the focus is. This is another model. This is an early model. Now, what's missing from this model, students? What's missing from this model? This is a great example of an information processing approach. So you get in the information, you set hypotheses, you pull from your knowledge, you come up with an intervention, you reassess. And you do the subject exam, physical exam. What's missing from this? Who do you need to understand to be able to? Yes, the patient. Yes. So you need to understand the patient, and particularly in our world, if you don't understand the patient and what they think is going on and how they might engage, adhere, or comply, or cooperate, if you don't engage in some shared decision-making, you're not going to be successful. It goes back to we don't have complete control over them. So this is where our complexity comes in. Clinical reasoning, really, really important piece. This is just another example. This is from medical education. And you can see, again, a very deductive approach, very similar, generate hypotheses, come up with, and for medicine, it's very much about a differential diagnosis. So what are they going to do? Physicians are going to refer, right? They're going to prescribe medications. They're going to, if they're surgeons, they're going to do surgery. So yes, in primary care, things are complicated, I think, but they still have a pretty much driven by the diagnosis approach. This is another visual, one of my favorites, from Ian Edwards, who did just a brilliant dissertation in research early on in thinking about, he's from Australia, so he took some of, Jeff Maitland did some of the early work in orthopedics and manual therapy on that kind of information processing approach. And what Maitland did, and he understood as a clinician how important understanding the patient is if you're going to deal with orthopedic musculoskeletal problems. So you see the kind of deductive process, pulling from what you know, but you also see the importance of what's central here is the patients in their world. Understanding the lived experience, the illness experience, the story of the patient. And from that, you are going to create, there is some social construction of what you know, your clinical knowledge, that occurs while you're in practice. And the more explicit we can be and the more scaffolding or things that we have, are you in a staff office where all they talk about is what they're going to have for dinner at night? Or do they have rounds and do they read articles and are they engaged in continuing to learn? Those are two different cultural clinical learning environments. When you have residents, we've got some evidence of some research we're doing on residency education, that residency programs in the clinical environment are lifting all boats because you're seeing engagement of learners who are really after their clinical expertise, and they're bringing it's changing the culture and the climate of what's happening, which I think is a great finding and evidence for the profession. All right, what do you see here? You see that, of course I put ethical reasonings in the center, but you've got to use diagnostic reasoning, narrative reasoning. This comes from Ian's work. He identified different forms of reasoning. But when you're managing a patient, then it's more about understanding that context. What's the procedural reason? What's the teaching? What's the interactive reasoning? What's the collaborative reasoning? I mean, his work really identified that reasoning is more complicated, has more dimensions than just the diagnosis. Diagnosis is important, but we also have to engage in management of the patient. Okay, so context does not impact clinical reasoning. It is clinical reasoning, right? And so how do we navigate that? All right, so the master adaptive learner, how do we do that? Central to your development as an adaptive learner is this metacognitive process, your thinking process. It is how you develop as an adaptive expert. An adaptive expert, an expert is not somebody who has so many years of experience and all these credentials. We talk now about an adaptive expert is somebody who can do routine practice very efficiently, but can also, when challenged with uncertainty, can do what we call, they can adapt in this innovation kind of corridor, really important. I think about your wife, Dr. Agrawal, as an architect, and I think if we had her today, the architecture has this design thinking piece, and design thinking has such application, I think, to that innovation piece. And there are a lot of architects that have been brought the design thinking at Arizona State. They brought that into the interprofessional team education. So think about that. And her legacy, that kind of how you think more creatively and innovatively. The top of our Miller's pyramid, our triangle of knowledge should be your ability to be creative, and that's part of adaptive expertise. Okay, and it also includes your ability to self-regulate, to self-monitor. Are you self-aware? Remember, learning is something you do to yourself. Okay, this is a great book. Bill Cutter and group out of medicine also published the AMA along with AAMC, did a series of books. This is a great one. Dr. Cutter has done, a couple of lectures in PT. He's down at Vanderbilt. And this paper is also terrific. And this is the model. I'll give you the simple version. It's far too much text here. But from looking at the right, how do we help learners plan? And your planning has to do with, okay, what do you know? And where are your gaps? And you do that by asking why, asking questions, right? But also seeing where your gap is and then going after it. So you're learning and you're using learning strategies to fill in what you don't know. You're not waiting for somebody to tell you. You're actively seeking that. And then you're assessing what you know, you're getting feedback, very important, and then you're able to use that and adjust that so that you can do routine practice, but you can also adapt with a novel situation, a novel solution to something that's more complicated. So this identifying the gap is really critical. You know, what do I know? What don't I know? How do I go after it? What have I learned from not being successful? That's another element of that. And then engaging in your learning versus somebody's going to do something to me. Somebody's going to give me the feedback. They're going to tell me what I did wrong, and then I'm just going to correct it. Also important in this model, and there's a lot of work being done, is the importance of coaching, not just advising, but coaching. And coaching has to do with these battery elements, they're called: curiosity, motivation, growth mindset, and resilience. And we talked about some of that this morning. Those battery elements of you as a learner are really important. It's not just what you're stuffing in your head or what you're thinking, but how are you curious? And do we drive your curiosity out of you? I think sometimes we do. So, okay. And I really believe this, again, the metacognitive process, learning how and what to learn, I think that's the holy grail in terms of what are we trying to do. This is all about the development of adaptive expertise. It's the foundation of the master adaptive learner. It is the foundation in the movement towards competency-based education that's happening in all the health professions, because we're preparing someone for lifelong learning, progressive problem solving. That's what we need to do. And what is metacognition? Who cares? Thinking about your thinking. It's being aware, self-awareness, And then it's being able to take control, to think, but then take action, and that you can self-regulate. Again, are you developing those self-regulations? And how do we do that? Well, we get you early on into patient care. And that learning, this is evidence that's come out of what do we see in learners that are becoming adaptive learners. They learn outside of patient care. Good. They learn from peers. You said that this morning. They ask why. They have this productive struggle with the uncertainty. They look for their knowledge gaps. They go after resources, and they have a mentor or coach. And again, the adaptive expertise, not someone who knows all the answer. It's, again, those metacognitive skills, self-awareness, as well as humility. Okay, so teaching and learning. This is the last piece. Hang on. I'll quickly go through. Where do we struggle? These are common clinical reasoning issues, and what happens with novices, you're in search of certainty. So sometimes you confirm, oh, we just had that. I think it's an SI problem because we just covered that in lab. So you tend to go, the first thing that comes to mind, you want certainty. I think it's that, versus sitting back and framing and seeing if you could frame it a little better. This is where the compare and contrast can be extremely helpful. Overconfidence, a problem. Premature closure, I think I know what it is. You say, oh, I think it's that, but you don't have the evidence to support that. You stop too early. So zebra, you're looking for a zebra. This often happens in medical. If you've ever seen residents practice, it's like they're looking for a zebra and they forgot about the common diagnosis, the horse. And they terrify the patient. Okay, so we need to help you organize your knowledge. What are things we can do? We can give you typical cases. We can change the features in the case. You can do this compare, contrast. Think aloud. You can think aloud. You can think aloud with your peers. Your faculty, your clinical faculty can think aloud. You use visual strategies, models. You take pauses. You share solved cases so you can see how you solve. You progress. You limit the feedback to 1 to 3 things. This is something they try to do in medical education with residents, to limit it to 1, because over 3, if you're getting up towards 5, you're in cognitive overload. And you emphasize that you're developing this knowledge organization. So what helps that? You've got to, these are things I've just said, compare, contrast, case features, self-explanation to your peers, this visual process. But how do we help you chunk the knowledge, concept maps are great tools, these pauses, reviewing what are the key elements here, not what's everything, working with peers, solve cases, think aloud, moving from simple to complex, and again, limiting the feedback. And what do we think? Again, these going back to the theory, dual process, right? We've got to be explicit about teaching both strategies, both fast and slow. So we've got to help you develop your own pattern recognition. They do this pretty well, I think, in residency programs. I'm just reflecting on the Kaiser program. They were very intentional about having residents really articulate clinical narratives. So what is not just what's the patient's age, diagnosis, objective, subjective, objective, but what's the narrative story in this case, including all of that. And when you get at the narrative, you get at this both the non-analytic together with the analytic. And I think the more we can do with narratives, we published a paper or 2 on this with our residents, but having residents and being able to look at residents and then looking at DPT-3s and DPT-2s and DPT-1s, looking at that strategy has been used a lot in medical education, different levels of learners and how you're developing your reasoning process. And cognitive load, we got to give you time to think. I am not giving you time to think. I know, this is the fire hydrant approach. I'm sorry about that, but you will have the PowerPoint. And different prototype cases, not teaching everything, but the profession, I think, has to identify. I think we, as a profession, are on overload sometimes. We've got to think about what are prototypical cases. Okay, and then we need to emphasize that you've got to organize your knowledge, and you got to use different kinds of strategies, analytic and non-analytic. And you've got to practice. We've got to find a way to do deliberate practice with you, with your clinical reasoning, not just with your, screening skills or whatever, with your reasoning. And how do you do that? Okay, then your faculty members become more coaches, like your CIs, your clinical instructors or preceptors. I think often take more of a coaching approach. And you can pull from motor learning, part task and whole task analysis. You can bring those principles in to the laboratory. But ultimately, it's you learning how to learn, which is something you do to yourself. And we can't possibly teach you everything. You can't just pull it in. You're going to learn how to continue to grow your knowledge, but you're not going to be able to grow your clinical knowledge without good clinical reasoning, metacognitive abilities. Those two things go together. That thinking about your thinking, paying attention. I know it's hard as novices because you're so focused on what you need to do. What's the next question I'm going to ask? But how do we get you to process the case? We could put more complexity or have more focus on the narrative piece of the case. What are the tools that promote your reflection? You experienced that today. Peer-to-peer collaboration, conversation, getting first and second year students to talk to one another. That's another ability to get a reflective process. Because the closer the peer-to-peer, it's not that we don't have any credibility. We don't have the lived experience that you have, and that's really powerful. So clinical reasoning, I think, is context specific, and that it's affected by your emotion and your motivation. And I think you're all motivated. You were all here this morning. You're all engaged, really engaged. And as I said, you were more engaged than I taught yesterday morning. You're more engaged than my students yesterday, so. Get high marks for that. All right, so remember, clinical reasoning expert it's not clinical reasoning expertise. It's coming together with the expertise, with the knowledge development, and your evidence of expertise is in that it's context specific. So if you're, this particular true in medicine, if you're a cardiologist, you probably don't have expertise in pediatrics. And so we talk about clinical reasoning being context specific. Now I think for PT, and it may be true for the other health professions, what is a generalist? Because we graduate generalists. And this is where our work in PT on competency-based education and the assessment process that will likely be EPAs, entrustable professional activities, assessment of student performance done in the workplace. I think that's going to help us identify what is it that you should be able to do unsupervised your first day of practice after you pass the board exam. That will help us calibrate as a profession. And we need to do that. We have lacked that kind. I don't know, speech and language, do you have the same issue? Yeah, so you can't just put everything. And you got clinical specialization, and then they try to stuff stuff in the curriculum. And if you put stuff in, then what do you take out? I mean, I feel for students sometimes. Okay, but we have to teach clinical reasoning. We have to be more intentional, explicit, and that's exactly what your faculty is doing, which is great. And this learning is lifelong. That's the most important thing we can do because you're going to continue to learn. And motivation and emotion count. This is where the clinic, you heard me say the most robust learning occurs in the clinic. Why? Because it's authentic, it's got emotion, it's got everything, it's real. And the earlier we can get you integrated in that, it's good, and stories are powerful. Clinicians, expert clinicians, they remember stories. You ask them about a patient case and a plan of care, and they will tell you the story. Absolutely. And peer-to-peer learning, very, very, this is where the different levels of learners, so if you have residents in your labs helping, or you have different levels of students, that peer-to-peer learning is extremely important. So you ones and twos, you gotta, talk to each other more, and get a few threes in there too. And tips for navigating uncertainty. This is also something we don't do well. We have to embrace the uncertainty in practice, and we have to promote curiosity over certainty. So are there things that we do in terms of our assessment of you that's looking for the curious dimension versus the certainty? And then integrate that into the curriculum. Not easy to do because we feel so pressured. We've got the CAPTE, the accreditation criteria. We got to get the board exam, and boom. And this is just a summary slide. This is the last slide. This is just mostly for the faculty. This will be in a chapter in the clinical reasoning book, but it's a nice kind of overview of the educational strategies, thinking about what you can do with the different theories. Just some ideas. All right, that was a fast tour, and we are at which part of the elephant are you going to tackle? And that is my last slide. This is we are Blue Jays, not Bob, and that's Billy Blue Jay with this. Oh, and that on the right-hand corner, that is our new health science building, which is wonderful. We built a new dental school. We used to be in the old dental school. We built a new dental school. They didn't make it an interprofessional building, big mistake. So the School of Medicine got really upset. And so we finally built this. School of Medicine has the lion's share in there, but we have classrooms, sim space. It's quite nice. And if you can name all the states that surround Nebraska, you get a star in geography. Any questions? We got 2 minutes. We got 2 minutes for questions, right? Gary, where are you? Yeah. Any questions, comments? Yes?
So I really enjoyed that you kind of had metacognition as the linchpin for clinical learning because I think that's really important. But those skills take a long time to develop. So I was wondering if you had any resources available, things like that people could turn to kind of aid them in thinking about how they're going to think about these things.
Yeah, I'll repeat the question. So the question is, went to a very simple question. You talked about metacognition, so it's kind of complicated. So how are we supposed to do that? What skill? How are we supposed to develop it? Did I got that right? Okay. I think that it goes to the deeper thinking about your thinking, which is how do we help you structure your knowledge? How do we help you develop a scaffold or organize your knowledge and put it together with your thinking? So I think there are different teaching strategies we can use. One of the things I talked earlier with a faculty is asking questions, and this came out of some of the early Carnegie work on scholarship of teaching and learning, asking about difficulty. Where did you struggle? What didn't you understand? And having that be part of the assessment. So we're going to give you points for identifying what you didn't understand about this case. So putting the focus on that versus it's that right answer versus putting the focus on the right answer, because that gets you to think more deeply about what's going on. And these are all connected, how you get to that deeper level. So it's that pushing. And I think the clinic has this a lot. I mean, I was in class just, and I heard one of the faculty members in class with me, very experienced, and this faculty member told the students, I've practiced for 40 years, and I can tell you, I am never always certain. I'm always going to get stumped, and then I just have to start to figure it out. So to hear somebody with a lot of experience and expertise say that, I think it helps learners go, oh, well, maybe there's hope here. But I do think there's the think alouds. It's that basic thing of show the math. You've got to get. We can't help you with your metacognitive process if we don't know how you got to that answer. And that we get through reflection questions, that we get through debriefing, that you get through peer-to-peer discussions, those kinds of things. How did you get there? That's thinking about your thinking. So we need to be more intentional. That was a great question. Not easy. I don't know, does the faculty want to respond? Or maybe the dean wants to respond.
Good luck with that. Okay. My experience with students, though, too, is it feels very risky for them to tell you what they're thinking because they're still learning and they want to have positive evaluations about it. And so my experience a lot of times is they're hesitant to give you that kind of insight about it because it feels like a real risk to put out there because the risk is what if I'm way off and I'm going about this all wrong? So I guess I had a related question to that. And how do you create a space where students actually feel really comfortable sharing that with you?
Yeah, no, it's a great question and gets to the heart of the issue. That's on us. So how do we structure the teaching and learning environment so that we're looking for that? You know, do we want you to identify, not the right answer, but do we want you to identify where the biggest challenges are? And then also curiosity, to reward curiosity and creativity. And I think we drive the creativity out. Now, I do think that I was just telling the faculty this morning, the Josiah Macy, Holly Humphrey just did an interview, and it's posted on the Josiah Macy website about how important the humanities are, liberal arts education, and why is it important? And her argument is it's important because you've got to be able to see that creative, kind of innovative approach to healthcare, because if you're only driven one way, you're really not going to be able to manage the current challenges in the healthcare environment. So it's a point well taken. We deal with the human condition. So it's, you know, and you can still integrate humanities into exercise science majors, I think, yeah? We have to find ways to do it. We have to do a better job on the undergraduate side. That's what I would say. Yeah. And I'm at a Jesuit Catholic school. We have a very strong core. We get about a third of our students from 80 students that come through the undergraduate, but they still are kind of chasing that, let's get through the core, the gen ed, because I want to go here. And so our medical school has done a very good job of integrating humanities, ethics and humanities in and offering, it's very creative, these one-credit selectives, and students have to take a couple of selectives in their first 2 years, and that's things on drawing, or a course on Dickens, and they're being taught by our undergraduate humanities faculty, which has been great. And there have been some great documents put out. So that's planting some seeds, because we can learn from each other. The other thing that's really important, I think the professional schools, we're not just the trade schools. And that's what the undergraduate faculty often think about us. We're the trade schools, but we're not. They need to do more kind of experience, because we get active learning experience, experiential learning. They have the humanities and that kind of human condition that they can bring to us. So we need each other, and there's been stuff written about. We need to shape the life of the mind for practice. That's what we need to do. Other questions? We're over. I don't know what do you guys have class today, or you don't have to? You don't have class today? Really?
Please see me afterward, Gary Claiborne.
How about faculty? Comments, questions? I could ask them questions. How do you guys do it? How do you do this? To the dean's question there. Make a safe space for. I think it's great. It's a really important.
Well, I would say I have more questions than answers, but I guess I'd like to hear more from you. I mean, I think the heart of the matter, as John mentions, is how do we as faculty promote that deeper self-reflective learning, self-directed learning? Yeah. Part of that course is providing a optimal learning environment and giving effective feedback. So I'd just like to hear more about your strategies for all of those things.
Well, a common concept was you can, when the initial kind of reflective thinking came out. I mean, John Dewey wrote initially about reflective thinking, and then Donald Schoen picked up Dewey's ideas, although the Jesuits would argue that they actually 500 years ago engaged in reflective thinking. But the importance about you can't engage in teaching reflection if you're not reflecting yourself. So that ability to do it yourself. But I think we tend to reflect too much back on the action and not in the action. You heard me talk a little bit about the assessment tool we use for practical exams. So that has a content piece, a procedural piece of knowledge, but it has this conceptual piece. And it's the conceptual piece, and we have a rubric, helps us identify learners that need more help at that deeper level. So it's helping us, what is it we need to do? But I think how do we reflect and how do we role model that? How do we role model curiosity? How do we role model uncertainty? I think those things are so powerful. And the other strategy I think is important is exactly what we did today. Getting faculty here with students and letting students hear you talk and tell your stories, there is no substitute for that. Those are things they're going to remember. You all are going to remember this. You're going to remember what you heard this morning in 3 or 5 years. It's going to be part of who you are, that unique piece. Those are important narratives that are part of your professional formation, and that's something nobody's going to take away from you. It's part of the uniqueness of this institution, of this program, in this institution, in this community, with that community of faculty. You're a community. That community of learning has to happen on the academic side as well as the clinical side. We're not separate, and we need to build a better bridge. That's the other thing I think that we struggle with in the profession. Those are a bunch of stuff.
I had one question too, and this is more for the academic people here and online, which I guess I can mention that we had probably typically around 80 people online that were from various schools in Ohio and other places watching today too. So a large attendance from that perspective too. My question though is something that we'll probably talk about later is a lot of what we're talking about here, we've got the faculty have some responsibilities in this whole process, obviously, in how we do things, how we teach, how we organize our curriculum and everything. The students have a responsibility in this in recognizing what they have to do as learners. For the faculty part, my initial thought starts going into how do the faculty do all the things that they're supposed to do right now and then start to incorporate all these things in, which in my head are going to take some time. How are you going to revise? How are you going to then come up with these things that you need to do? How are you going to make those decisions to get rid of whatever you're going to do and still hope that you get enough in? All of those things happening real time. Where do we get the workload time to do that?
Ask your dean.
That's why I'm asking right now, because he's here.
Well, here's what would be my response. I mean, you're engaged, and to me, curriculum is about people. It's not just what's on paper. And you're engaged in a very, I think, robust, highly energetic way of how do we become more intentional about this. And to me, you have to think about ways to find energy. Is there some scholarship piece you're going to share? Are you going to collaborate and move this forward? Are there some people on your faculty that are going to use this as a way to track their scholarly work? That, to me, is a both and it gives excitement. And you can have students involved in that work as well. One of my pet peeves, as you know, I'm very fond of how do we develop more education researchers in the health professions? And in fact, John, to that, we do this grant writing workshop in mentoring in medical health in education research, and we have ASHA involved this coming year, and you could send faculty there. It's going to be in September at Medical University of South Carolina. Loretta Nunes and Gus, they're both, and we have AOTA that's going to partner with us, so it's all good stuff. So how we see our work is teaching, learning, and assessment. So our teaching and scholarship are two sides of different sides of the same coin. And I think that we have given short shrift to education research, and we've put the emphasis on clinical research, and to an extreme. I would say that in the profession, having been, never had a startup package. I did get a tape recorder one time when I started someplace. But, I brought in money, training grants and other things, but I never had a startup package. But the need to collaborate and find energy and do bake sales and, no. But to get, it's hard to get funding for education research. That national study, that Carnegie-like study we did, we worked for about 3 years to try to find money. We went to Lee Schulman because he was my dissertation chair just by accident. And Lee said, it's hard to get money to do education research. So we we bartered, and we finally found ways to put it together. So making that a reality among your faculty, among some of your faculty, you've got all sorts of lab space. Can you create a learning lab for your faculty here that might be cross professions, that is looking at some of these really important issues that we share across the health professions? And you probably have seed money available, right, Dean? Yeah. So I think I think it.
Talking about money, yeah, you wanted to who turn off the recording. So Dr. Gupta's here today, though, and in addition to bringing in people like Dr. Jensen, there are chances for mini sabbaticals, too, so the faculty have a chance to get that kind of space. I would say that's very innovative and appreciative because Dr. Claiborne brings up exactly what the point is. It's not the desire, it's not even sometimes the ideas, it's, okay, I just need that 3-week period of time to put that together. I need to not be doing some of these other things so I can do it. And so it does require that kind of investment to do it. So I'm happy to bring up resources to this group because fortunately that's been endowed, so that's great. But in other cases, nursing, for example, where they're always just dealing with high volumes of students to try to find, okay, well, where's that time going to be to innovate? Yeah. They do it through a lot of committees, actually. They bring people together and just designate people to do it, and that's how they handle it on a workload end, is to say, okay, everybody's going to be on this committee, and then they innovate a curriculum piece. Yeah. Sometimes it's driven by your accreditor, though, as well, who'll say, okay, we need everybody to demonstrate metacognition in your learning process, and we're going to check you on that in your next report, so tell me about how you did it. That empowers an administrator to then say, oh, okay, well, we've got to make sure that people have that time then in their curriculum. So I would say your accreditor is really powerful as well. If this is a value, then of CAPT, then they can say that.
Yeah, and I think what you're going to see with competency-based education movement, I think you're going to see those kinds of it won't be mandated, but I think you're going to see those kind of opportunities. I think the finding ways to identify collaboration within your faculty community across health professions or across programs. But I have to say one of the outcomes of our grant mentoring graduates, we've had 5 years of graduates, is they've gone back to their departments, to their programs, and they've created a learning lab. There's one at WashU, there's one at KU, we have one at Creighton. You'll see tomorrow we've developed some resources with clinicians for clinical reasoning. And so that gives a kind of structure, very much like our colleagues do in their clinical research, where they have all the fancy equipment and stuff, and I saw some of yours, right? So you got to create that kind of structure and energy to collaborate. But then you also think strategically about what are we going, what kind of seed money, how can we continue to do the work in this area, versus it's just about getting the accreditation done, or it's just about addressing the ClinEd thing. You've got to have your you've got to be able to integrate your scholarship in that way. And it's tough, but it can be done. Collaboration helps a lot.
Any students have a question? I could throw up a couple more, but I'm happy to hand off to a student. Okay, I guess since I have the mic, I'll just ask you. I'm curious to know, again, that maybe some examples in your program, how you've shifted over to that more deliberate practice of implementing more CR in your program, because I think obviously you hit the nail on the head there as far as the tendency for a lot of the education to be so cognitive overload and less of that deliberate practice. Could you speak to that a little bit?
Well, I can tell you that Creighton's not perfect in this. We have a lot more to do, but I think, again, it helps. I've worked with a lot of the younger faculty to help them with some of the conceptualization and the development of the tool, but having that group, so now you're seeing them integrate that into their teaching. So it goes back to what your endowment funds are doing here. It helps get the faculty developed so they bring that and are doing it in their classroom. The other thing that's happened is the collaboration around the scholarship. So the blueprint article, the involvement in the symposiums, that has been good to see they have a path for advancing their careers, but it's also having an impact on the curriculum. I think it is. Is it perfect? No. There was something that was started, and it kind of fits and starts. But there was some interest in doing a cross-health professions clinical reasoning club for the students. And I thought that was a great idea. It'd be, that as an interprofessional activity would be pretty cool to get students from the different health professions talking about clinical reasoning. That would be great. And that would have real legs. And I think this issue of management reasoning, I think, is an interesting one for teams, because it's not just what we know, but how are we going to manage the care of the patient as a team? So, and Steve Durning calls that a team sport. He's right on. Because physicians can make their diagnosis with AI now. They're a little worried about that, actually.
All right, well, I hate to be that person, but Dr. Jensen has such a deep well of knowledge that we are fortunate she's going to be here the rest of today and then again tomorrow. So just a reminder that she's going to be giving another lecture tomorrow from 12 to 1 in Grover, West 115, and also online. But thank you so much for this introductory lecture, and we look forward to what's to come.
It's great. As long as I get to drive back to Columbus in the light.
I will try to make that happen for you.
Right.